So, welcome to our Women in Otolaryngology webinar titled Sharpening the Scalpel. We're going to be talking about the role of surgical coaching in otolaryngology. Um, as a reminder, this webinar will be recorded in its entirety. And then, if you have questions, please share them in the chat and we'll address them at the end. We have a great panel today where we'll start off with a little bit of an introduction on what surgical coaching is. We'll have a sample coaching session, and then we'll end with some more um, insights into the benefits of surgical coaching and its role in also uh, uh, training residents and other trainees. So, as a bit of an introduction, my name is Cynthia Wang. I am a assistant professor here at UT Southwestern in Dallas, Texas, in pediatric otolaryngology. We're joined by three esteemed coaches today, the first of which will be Dr. Padilla. She is an associate professor of pediatric otolaryngology, head and neck surgery at the University of Utah. She's also a certified member of the Academy of Surgical Coaching, and she is actually spearheading a coaching program within her department currently. We also have Dr. Lakeisha Henry. She is a clinical associate professor of the Uniformed Services University of the Health Sciences. She's also a comprehensive otolaryngologist and is practicing in private practice at the Ear, Nose, and Throat Consultants of Nevada. And last but not least, we have Dr. Lee, who is a clinical professor of otolaryngology, head and neck surgeries, specialized in otology and neurotology at the University of British Columbia in Canada. She is, in fact, a board member and a certified coach of the Academy of Surgical Coaching as well. And she is also the director of QI and coaching at UBC. So we have a lot of experts here on this panel, and I'm very excited to get things started. We'll go ahead and get started with Dr. Padilla, who will give us a quick introduction into what surgical coaching is.
All right.
I'm going to stop sharing.
Okay, perfect. Um, Let me make sure we have everything that we want. Okay, Dr. Wang, is this better?
That's great.
Okay. Well, thank you for the introduction. I am really excited to be a part of this panel. And yes, I will start off by just talking about what surgical coaching is, and why it differs from other things that we may have experienced in our career. So we really want to start out with definitions. We have different terms that have been thrown around, in our training and in our education, whether it's mentoring, sponsoring, or coaching. And the goal is to delineate these three separate relationships and how we can utilize all of them to its max degree. So mentorship really is when an individual guides a mentee through life decisions or career choices. So really kind of sharing their own experience and knowledge to say, hey, this is how I did it. This is how you may be able to accomplish your goal. Sponsorship is when you showcase and promote an individual. So if I was talking to another fellowship director and I said, my resident, they're really wonderful. I think they would be a great fellow in your program. I am promoting their career. Teaching, a teacher provides knowledge to a student, and there is an endpoint. And these three relationships are hierarchical. There is someone who has more power or more knowledge that they're instilling into the other individual. Whereas coaching is not hierarchical, it's more kind of coexistence, co learning. The coach does not necessarily have to be an expert in the field, and they really tend to the coachee's needs. And there is no endpoint. And I can attest to that. I feel like I started a coaching relationship and I feel like it's benefited me so much that I'm going to continue it. Where do we typically see coaches? Well, our minds immediately go to athletes, sports. We have executives, and even with the athletic world, like I talked about, NFL coaches, NBA coaches, they themselves are not always necessarily prior players themselves, but they can be great coaches without being a player. Celebrities, musicians. And so, us as surgeons, we really have a great opportunity to utilize surgical coaching. Um, and in fact, the New York Times earlier this year put out this opinion essay that showcased how important it is, especially in our circumstances with life and death and where the stakes are high, to utilize coaching concepts. So, where can we perform surgical coaching? Well, obviously the operating room, that is a place where surgical coaching can occur. But I think also in clinic, being able to observe your mannerisms, your dialogue, your eye contact, posture, all of those things that you may not be aware of at the time. And while wellness is this third section, I really think it should kind of overcast everything, because if we are better, more efficient, our relationships are better in the operating room and clinic, I really think our wellness improves as well. So why is this important? Well, we have a very special skill and we have a very important responsibility. And there is research to show that our complication rates, our operative times kind of plateau mid-career. And what that definition of mid-career is, well, it can be 5, 20 years, kind of depending on what surgeries you're performing. But that plateau is where surgical coaching kind of can help you out of and continue to improve. How do we advocate for surgical coaching to leadership? Well, if we can improve patient care, less morbidities, less mortalities, better resource utilization. If we can decrease time in the operating room, we can improve efficiency and do more cases. If we can improve relationships with patients, families, staff members, less grievance calls, less patient satisfaction issues. So, when we are better and doing better, everyone benefits. Atul Gawande had a great talk at the New Yorker Festival. And if you haven't seen it, I would highly recommend watching it. But one of the things he goes through is this kind of sequence of events that occur when you're learning a new skill. So it goes from this unconscious incompetence. So you don't know where you're lacking in skill, to conscious incompetence, where now you know where you're lacking, conscious competence, where, okay, now you can perform this skill with effort, and then unconscious competence, where now you can perform this skill automatically. And surgical coaching can really play a role in each step of moving towards that kind of level 4 competence. I like this diagram a lot too, because the Dunning-Kruger effect, if you're not familiar with it, it shows that individuals who are less competent actually have a higher perception of their competence, meaning they don't have the insight into their incompetence. And again, that's where surgical coaching can be helpful, where you have this outside observer who can kind of point out areas of growth. This other diagram I felt like really hit home. You're a medical student, you don't know anything, you're a chief resident, you're on top of the world, you feel like you know everything. And then slowly you're kind of moving down, first year attending, you're like, what am I doing? But then knowledge gets more, your confidence gets better. And we want to continue to improve and go up on this graph. Surgical coaching, like how exactly does that work? Well, you can have live observation, video observation, but if you don't have the capacity to do that, even a description of a procedure or a clinic visit is helpful, where the coachee kind of describes the situation and goes through what goal they want to go through. And again, the coach does not have to be an expert. So my surgical coach does not have to be a pediatric otolaryngologist. They can be a neurotologist. They can be a urologist. They can be an OBGYN. As long as the coach has the skills, they can be an effective coach for you. And I have a few examples of, really successful athletes. We have Kobe Bryant, who talked about when he watched film, he didn't watch what was there, he was watching what was missing. So similarly, if a case goes well, that doesn't mean that you can't learn from it. what if this happened? What could I do to prevent a complication? Or what would I do if this happened? Um, in the sports arena, there's nothing like training and preparation. You have to train your mind as much as your body. So, similarly, training yourself through those videos to be able to prepare yourself for the next case. And then, Mia Hamm, final measure of athletic greatness is not what you do in training, but it's what you do on your own. So after residency and fellowship, we can't just stop. I always talk about, seriously, I wish somebody would just come in the operating room and watch me operate, tell me what I can do better. And that's where this is really impactful. And so, when you're reviewing film, just like in sports, you're reviewing what you did, but also your teammates. So if one of your goals is how can I utilize my assistants better in surgery? Well, if you're observing the video and you see, well, maybe the surgical tech is talking to someone else or is not engaged, that's something that you may not be aware of at the time, but when you look through it via a surgical coaching relationship, it could be helpful. And then our opponents, like who are our opponents? Well, it's really complications and challenges in the operating room. And this is where you can review potential complications or complications that did occur. And then lastly, the literature is really heavy in general surgery and OBGYN, but isn't as strong in the otolaryngology literature. We recently published something about the evidence for surgical coaching in otolaryngology, but with microscopic, endoscopic, robotic, open cases, we're so well poised to dive into this that I'm excited to have our other panelists go through kind of how it actually works in real life. And then I love training residents and fellows and kind of taking creepy pictures of them. So here are just some people I've trained in the past. So thank you for that. I'll stop sharing.
Thank you, Dr. Padilla.
I'm unmuted now. Everyone can hear me okay? Just a heads up, we're going to show a bit of a video, and the audio quality may not be ideal, so feel free to turn on your captions, just in case that's something that works for you. I just wanted to go through a few disclosures before I enter the room. So as mentioned, I do have some affiliation with the Surgical Academy for coaching as a board and coach, as well as faculty. Any money I do get paid goes back to them and is donated, so hopefully that reduces some of my bias. I've had a Royal College grant for creating a surgical coaching program, and I'm a certified coach at organizational coach for the University of British Columbia, and I also have a private coaching business. And then anything I showcase a little bit later, just wanted to clarify that this is within the Canadian medical system. And we're going to go through a coaching session, but I thought just before we do that, so you have an idea of like kind of trying to follow the arc that we're going to do. Typically, we start off like with a peer-to-peer typical coaching session. It starts with co-creating an agreement. So that covers confidentiality, boundaries, preferences, safe space generation, and then goal setting. Sometimes then you can go into either video review or observation. And then you really get into that fun stuff, which is like guided inquiry. And again, the video review is not necessary. The guided inquiry is this exploratory phase that really helps to facilitate understanding and encourage self-reflection among the coachee, and sometimes with permission, challenging perspectives, and then feed forward. So instead of feedback, typically focusing more on what do they want to do differently next time. So more not past focused, but more future focused. And then action planning, so setting plans in motion for how you want to improve and then repeat. So that's sort of what you're about to see. We only have probably about 15 minutes or so to do this. So bear with us. And I wanted to thank Dr. Henry for agreeing to be vulnerable and sit in this space as a coachee. So we're just going to get started. First of all, Dr. Henry, how would you like me to address you?
You can address me as Dr. Henry or Lakeisha. That's fine. I mean,
Okay, great.
it's, more informal relationship. So Lakeisha's
Okay.
fine.
And please call me Jane, so I'll call you Lakeisha. And if I know most people are off camera, but if you are on camera, just so it can feel like Lakeisha and I are like solo, if you are on camera, if you could just turn your camera off just for this coaching session, that would be great. And Lakeisha, I usually start just by going through confidentiality to reassure you that everything we talk about is kept between you and I, unless there's harm to yourself, harm to others, or criminal activity. But that is clearly not the case today. There's lots of people in the room watching. So just so everyone's aware, this has not been rehearsed. I have seen the surgical video in advance. Um, so just wanted to start, Lakeisha, how are you feeling doing this today?
I'm fine. I'm kind of excited about doing this. I think it'll be interesting and fun.
Great. And is there anything I can do to help create a safe space especially with all these people watching? Anything I can do?
Oh no, it's fine. I
Okay.
can't really see them because I don't have that screen on.
Yeah, neither do I. And is anything out of bounds for our conversation? Anything you want
No,
to keep
no,
separate?
everything's fine.
And I know we've kind of gone through role clarification, but anything that you want to ask about what coaching is versus mentoring or teaching, or you're pretty good to go on?
I'm pretty good.
Excellent. And then just so I get to know a little bit about you, how do you prefer feedback?
I I prefer feedback pretty much any way that I can get it. I mean, it can be something that's written, it can be verbal, it can be on the spot. I mean, I'm pretty open to feedback.
Okay. And do you prefer kind of direct feedback, or are you looking for like more of a conversational type feedback? What works best for you?
Both. It just depends on the situation.
Okay. Okay. If at any time things are not sitting well with you, just do this and we'll reset, or if we're going out of bounds. And before we begin, anything you think I need to understand about either you or your situation before we begin?
No, I think specifically for the audience, they just need to know that that I didn't plan how the video would turn out, and so I think that's what makes this a good example.
Yeah. And so, just for the audience, I received a 35-minute video, which I've watched in detail. We'll share a little bit with that with you next. We'll do sort of abbreviated because we don't want to spend too much time on the watching. We want to spend more time on the coaching. But Lakeisha, thank you, because most people, when they're in this position, let alone with people watching or they're new to coaching, they tend not to send something that's a bit of a doozy, that's vulnerable. So I just wanted to thank you in advance for sharing that vulnerability with everyone. So do you want to just set the stage? I'll show a video, but want us to set the stage about what the video was and what your
Sure.
thoughts are about where you want this to go today.
Absolutely. So this is a video of a patient undergoing thyroidectomy, and I'm learning different ways to perform videos with different equipment in the room. I'm in private practice, and so when I operate, I'm at the hospitals. I'm not in the same room. I don't have the same team, and sometimes with endocrine surgery, I'm doing teaching with general surgery residents.
Okay. And just setting the stage for this video in terms of what the focus is for this video, what you want to focus on.
So some of the focus is, I would say, when there's external factors, not the actual surgical technique, but external factors that can occur, how you might manage them on the spot. I mean, there's different people that you're teaching. You're teaching the surgical assistants, you're teaching residents, you're interacting with the room, and then there's things associated with equipment and how do you navigate those types of challenges. The video's still right now, and so there's the nerve integrity monitor, so the NIM is on, and I have a GoPro on my chest. I've tried the head and some other positions, and head gives you a headache, so this chest view seemed to work the best, where you could at least see some of what we were doing, but also because it has audio, you can hear some of the conversation.
Excellent. And just to set the stage, the video will show that the NIM monitor is not cooperating in this case, and that so we'll kind of demonstrate that. And just to recap, and just so that we're clear before we show the video, in terms of external factors, you listed a few there, from equipment to, new staff and managing that kind of non-technical aspect. Is there one element, because we're very kind of, usually these sessions are an hour, is there one element you really want to focus on today within those external factors? Or are you open to exploring and see where it goes?
I'm open to exploring.
Okay. Okay. So let's and one more question. If you were to leave this session 12 minutes from now and you kind of left and you're like, that was worthwhile, what did you leave with?
I would say probably a little bit more of how I can be a bit more efficient and effective. I mean, I'm calm throughout, but maybe a little bit more efficient and effective at rallying my team to work through the challenges that we had that were from setup to equipment, etc.
Excellent. Okay, so I have a very clear idea. We're going to play some of the video, bear with me. We're going to be skipping ahead, so it's 35 minutes, so we're going to start.
You don't have to worry you were thinking of it. It was making a slightly different sound, but now it's just okay.
So I just want to comment that there's something that's fallen. There's also the lines, and then there's like a, I don't know, macrame of cords and things of that nature.
Excellent. And feel free to keep, like, if there's things that I'm just going to randomly be stopping. So if there's things that you kind of want to like point out,
Sure.
Then just do that and I'll pause. Does that sound good?
Sure.
Hey, I'm at Sunrise. I'm doing a fibroid and the nerve Sunrise. And so the nerve monitor, even when we're not touching the patient, it's like making noise, just constant noise. We tried adjusting the tube and it just keeps doing this over and over. No, the patient's been pretty deep and it just.
Okay, where's the bed controller in conjunction to the patient interface, the patient line?
They're kind of close. They are kind of close.
Yeah, move that way.
Like move the
The bed controller.
okay.
Not close to each other anymore. So they're not close. They're still making crazy noise. Like, you know.
So here you can see that because I have the GoPro on my chest, as I move around, you can see things that are kind of on the floor. You can see in front of me, and you can hear that I'm talking to someone. I'm talking to someone that's not in the room. We've already changed the machine. We've changed a lot of things to control this, and it just, every time the patient breathes, there's this annoying noise.
And this is not part of a typical coaching session. The main reason we're showing the video is to sort of bring the audience in to sort of see what we're seeing. Typically, what I'd say to Lakeisha is there a part of this that you want me to watch in detail? Because you've reflected, you've watched it. Is there a part that you want to focus on? So I don't know if you know that answer, but that's usually where I'd start.
Probably your any comments that you have or feedback that you have in terms of my interactions with others, and it may be more challenging for you to understand who they are, but there's anesthesia, there's a one surgical technician, there's a rep on the phone, there's the general surgery resident, and myself.
Yeah, so that's helpful, right? Because there's a lot of different voices and we don't know where they're coming from when we're watching. So knowing who's in the room is super helpful. So we're going to watch just a bit more and then we'll get back to coaching.
Yeah. Pick the pipe up here. Or, he's a dentist. So he's a pipe plug in, but he's not laying down.
And then we're going to go to this part because I think that this is kind of interesting to show the cognitive load and what you had to do here.
But then he has to disconnect the electrode thingamajiggy. Chronic type B dissection. There's a who? There's a chronic type B dissection here that he wants us to see. So
I'm going to pause there because we're like 20 minutes in. And so at this point, now who I assume is your resident is like trying to bring a consult, and you're 21 minutes into. So just wanted to, so you brought in a few things. You brought in the chords, things that had fallen. You brought in the multiple different voices and people in the room. And now you're having cognitive load with people on the telephone as well as people in the room, multiple different conversations, beeping going off. So why don't you just set the stage for how you're feeling at this point?
So anesthesia doesn't quite understand the magnitude of every time the patient breathes, the monitor goes off. And in the video, you can't actually hear how loud it is. And even if you turn it down, it's extraordinarily distracting. The more senior general surgery resident is like, well, why don't we just turn it off? The more and at that point, I also have a junior, like a PGY2 general surgery resident. And that resident wants to understand why ENT uses it and why they may not. I have the technician who's trying to move stuff around, and they've put cords on completely different than I would normally put them on with the patient. And my personality is that I don't want to, I want people to learn, but I don't want people to be afraid. And so I want them to be able to speak up. And so one aspect for this particular surgical tech, because we ended up changing some of the cords, was, think about what you're doing and why. And if you're insisting to put all these cords because you think it's going to be easy for you, is it going to actually be easy for me as a surgeon and with my those that I'm teaching? And how are you going to unmacrame this mess of cords every time you want to hand me something?
Yeah, so the macrame is a very metaphorical thing that I fully understand. And just you mentioned there you want it to be a place where people can speak up. How do you go about achieving that? What's your approach to that?
In the beginning, especially if it's people that I haven't worked with, I introduce myself. I ask them questions. I tell them that if there's something that they see that they think is unsafe or they have some suggestion, I am always open to suggestion. And I also tell them that I'm gonna have tunnel vision, especially when I'm wearing loops. I'm not gonna see what they see, and so it's okay for them to speak up, and we can all learn from each other. So most people are pretty comfortable with speaking up and making suggestions.
Yeah, and what the audience doesn't see is there's this video that goes for 35 minutes where the calmness and the tone, I mean, this was played at 1.5 speed, so Lakeisha wasn't talking that fast, but you'll see the calmness really sticks throughout the whole session, even though about probably 50 different things were tried and nothing made the beeping stop. So ultimately, it sounded, from my understanding, is you had to go back to the old-fashioned way and do this without a monitor and just find the nerve. Is that an assumption?
Essentially, we changed machines and everything, and we left the machine on in the background and turned the volume down. We didn't cut any of the actual cords, and eventually the rep came in to actually take a look. Because I didn't want it to happen again. So,
and you mentioned the cords. Do you think that positioning of cords or having a standardized way that everyone knows? And I'm aware that that's difficult because you have new team members. Is there a way to make it standardized for maybe your thyroidectomy procedures, or is there what are your thoughts on how to make the cord macrame better next time?
I think it really stems from where the equipment that the cords attach to are located. And sometimes the insistence that I stand on the pad, and forgive my terminology because I really don't know what that pad's called, but we call it the princess pad all the time. And um, you know, both genders use it, but we call it the princess pad. And so some aspects of you know of thinking about the princess pad as not being sort of the only space that I'm going to stand in, and sometimes there's that you get trapped in this idea that, well, the surgeon's only going to stand here, so you can put stuff elsewhere. Well, it becomes a bit of a hazard because you've got cords where I can't move, and if I want to go to the other side, especially in a teaching situation, I don't want to be trapped within the cords. And so there was this uh, thought that if they brought the cords a certain way, that I wouldn't be boxed in. But
Right.
I still was boxed in because you could see when I step back, there's all these cords, and then the location of how they went over the patient. Some people turn the patient 180 degrees, but every room is very different. And when you have different anesthesia providers, CRNAs and residents and so forth, um, I find that being closer to anesthesia, especially in these types of cases, is really important. And I don't turn 180 degrees, and I don't know whether the turning 180 degrees would have ever made any difference. But
Yeah.
just having that conversation, and so I was willing to try, their approach, which I'm not generally very dogmatic, and I think the willingness to try the suggested approach for that particular room just didn't work out.
Yeah, and we all recognize that that happens from time to time. Um, I know that we have like there's so many different directions I'd like to go, but just curious, like I think I don't have the room set up, so I can't comment, right? But
Mhm.
if anything you can do to standardize, reduce variability is usually a good way to go. Is there something you think that can be done to do that in terms of room setup that would then facilitate cord setup? And I know that has nothing to do with the NIM not working
Sure, sure.
necessarily in this case.
It's challenging because this is not I'm this is not a hospital that I'm at all the time. And so I don't always have the same room. I can't really request the same room. And each room is different. You've got so many different factors, like where outlets are, where the booms are, um, the size of the room. And so most of the time, I try to focus things on where the head of the patient's going to be, and trying to put all of the equipment generally like at the foot of the patient or on one side. And so what they generally will do is put most of the equipment a little ways behind me, so that all those macrame of cords are actually coming out from the head of the patient and then off away from me. And so I'm not trapped in, and no one else is trapped in. And the nerve monitor is on the opposite side. So
Opposite side.
see it. Right.
Right, right. And in this case, it was on your side, behind you, yes.
It was initially, and then
Yeah.
we had to,
They moved they moved a lot
yeah,
of things.
yes. And then the asking, it's like, oh, gosh, we have to unplug this and all of these other things, and how are we going to get the bed in here? And um, so it is what it is. And sometimes it doesn't matter which side it's on, especially if you're going to trade sides to look at the nerve.
Yeah, exactly. And if we didn't have time, there's so many different avenues I would like to go, but I'm just gonna end with this question. If I was to throw you in this room today, same patient, same case, you're right at the start of the case, what would you do differently next time?
I would most definitely would talk to the team a little bit more than I did, and I would just talk them through what I'm going to need to do in terms of positioning and residents and so forth, how many are going to be there, and then get a really good handle on how whether or not my surgical technicians had they done this case before, and did they really understand what we were trying to do.
Yeah. And how, and we usually say in coaching, how are we going to hold you accountable to make that as part of your brief? Accountable is a word that I don't really like, but how do I hold you capable next time you're doing a briefing to include this type of thing where, we're usually tunnel vision focused on the patient, but the room setup, where things are, what's plugged into what, where the cords are.
So ironically, about a week later, same two residents, same anesthesia provider, different surgical tech, but the one that was there for the predominant case actually had to come in and provide lunch to one of the persons that I knew. And so we started off going back to, this is how I prefer the room to be set up, and this is why. And I don't normally put that type of stuff on my preference card, but the technician that knew me more said, how about we just put this on your preference card? And the two residents, I said, today we're not going to have these problems with the nerve monitor. We're not going to have any of this chaos. And so
wonderful.
Everybody was happy. The next case
comes full circle, right?
Faster. Yes.
Yeah. And I just want to end with this, but what do you want to celebrate about yourself watching this video and from this experience?
Well, I think the one thing that the residents really gained from the entire experience was the ability to be calm.
Mm-hmm.
Because you still have to move things along, and you still have to make sure that the patient is safe. And so you can certainly spend less time, like 5 minutes, and throw out the nerve monitor. But if something happens, particularly at that particular facility, there will be this discussion about, well, why didn't you do this, or why didn't you do that? And so I wanted to make sure that I covered all my bases, but I also utilized that time to make sure that it was a teachable moment, not just for me, but for everybody in the room.
Yeah. And, what came through for me, in terms of, feedback is that calmness. And I don't know if you're like a duck where you're paddling like crazy underneath the water and just so chill. But your tone of voice, you never showed any frustration. You may have said a few tiny things, but it was more about the situation, not at anyone. And it was clear that there was a lot of psychological safety in the room, even if you didn't know them that well. Because people were speaking up and giving ideas, and you were accepting them and then moving on, not just ignoring them. You actually did something with each of them. So just wanted to end on that, because coaching is also about strength spotting, right? And what you can grow and continue to be strong in. So I'm going to end this session there, so feel free to come back on video. And for the organizers in the room, do not worry. My next talk is shorter. The next section is shorter, so we're going to get right back on time. I know we took a little bit longer there, but are there any questions? You guys want to have questions just at the end? You want to keep going? I'm looking at Rima and Cynthia for that.
We can keep going.
Okay. So, these are like research shows that surgical coaching can help with these 4 performance domains. And most people come with like safe things when they start. It's usually, I want to be a better teacher. And so like they very rarely come with the ones that are hard, which is cognitive skills, self-regulation, interpersonal skills. And Lakeisha just threw a video in that does all of those non-technical skills. A lot of people come for technical skills, especially earlier in practice. But I'd also add a few other categories that coaching really works for: ergonomics, wellness, career planning, any career transition, new to practice, new job, new location, new leadership role, like planning retirement. All these things are perfect categories for coaching impact. And we're not going to go delve into literature, but it's here if you want it. In terms of literature review, surgical coaching can lead to improvements in technical skills, enhanced skill acquisition for new techniques, and also a reduction in operative time. And in terms of cognitive skills, surgical coaching can improve accuracy of skill self-assessment. So it really helps us self-reflect better. It gives us that time, that space to sort of watch a video of something we've done and reflect on it. It gives us more insight and more accurate insight because it's followed up with an external person's opinion. And there's also an improvement in procedural confidence, and recipients tend to find it more valuable than traditional continuing medical education. And I think that's largely because it's individualized and personally tailored to you. It really meets you where you're at, and it values what matters most to you. And it's also been shown to improve teamwork and communication skills, both individually and as a team. And reduce rates of emotional exhaustion and burnout. It's even better to have coaching. It'll actually keep burnout at bay, increases quality of life and resilience scores, improves job satisfaction and retention. The Cleveland Clinic has shown that there's like cost savings to this physician retention portion by implementing a coaching program, and saved like $133 million, which is crazy to me. And so I'm going to spend a few minutes talking about setting up a surgical coaching program in Canada at the University of British Columbia for surgeons. So different, a little bit different in terms of the medical environment, might be some differences there. So just want to acknowledge that. I did my surgical coach training with the Academy of Surgical Coaching back in 2019. And then I returned and shortly after launched a pilot at our academic hospital in the Department of Surgery. And the success of that pilot led to some grant funding from the Royal College. And then we created this University of British Columbia Coaching for Excellence in the OR program, calling it that to show that this is not just for those that are struggling, it's for everyone. It's the high performers to help them stay in that unconscious competent state. And accredited, it became an accredited coaching program for surgeons, and we even expanded to include our anesthesia colleagues, which was quite fun. And then we expanded from our hospital to all the hospitals in the greater Vancouver area. And we had support for training, program support, payment for coaches. And we also had CME credits, what we call maintenance of certification here. This program was from 2021 to 2022. It ran for about a year and a half. We had 16 surgeons, 12 anesthesiologists participate. And then we evaluated the program with surveys and post-program one-on-one interviews. And so here you can see the coaching goals were mainly in the technical or non-technical skill categories, but we also saw several in wellness, workflow, or even human resources. And almost all participants either agreed or strongly agreed that participation in the program led to an improvement in technical and non-technical skills, integrated continual performance enhancement into their practice, improved collaboration skills, and for the most part of the program, most of them helped them achieve their personal goals. And in addition, I thought this was more important to me is the statistic that 100% of participants intended to continue their relationship with their coach, which was really interesting. And some people even did a peer coaching reciprocal, so they switched, which is a great thing to foster vulnerability. And the program was also highly rated in terms of satisfaction with the coaching relationship and overall satisfaction with experience in the program. And almost all felt supported by the coach and felt more connected with colleagues from participation, which is also improvement, like a really important thing to feel that connection at work. And some of the coaches were quoted, you guys can all read these, but some of them is, liking that it was tailored to their specific needs. So meeting them where they're at, building confidence, also in sense of trust and collaboration with the OR team, improving quality. And one of them said it helped them think about how they want to evolve my practice, as well as validated their perceptions of some of the challenges they were facing. And then improvement in certain skills as well. And I think personally, if you're improving, you're probably happier, and happier surgeons are likely to perform better and get better outcomes and probably have longer, more fulfilling careers. And so just to close just the next few minutes, just to talk about setting up a resident coaching program. So we've done this at the University of British Columbia. It was funded by the Division of Otolaryngology through the Postgraduate Medical Education Department. And we had 13 residents participate since last November, and they seem to love it and keep knocking on the door to come back. 8 were junior, so level 1 and 2. 5 were senior in level 3 and 5. And as you can see here, there's a bit of a difference in terms of what they're coming for. It's largely non-technical skills, so stress regulation, interpersonal skills, cognitive skills, and then the work life and career planning. Most of it is coaching. Some of them want mentoring, but even when I'm mentoring, I'm often coaching and they don't realize it. So it's kind of an interesting process anyway. And so this shows that a formal resident coaching program has benefits. You could read that, most of them are quite happy with how things are going in the strongly agree or agree thing. But I'd say it doesn't have to be a formal program. You can implement coaching in day-to-day activities with residents or trainees. You can have them set pre-procedural goals in advance, then observe their performance, and then do the debrief. So if you don't set goals and you don't debrief, I do this before the OR and then after the OR. I get them to send me emails with their goals and then debrief in between cases or at the end of the day and give them a chance to self-reflect, do their own evaluation. The beauty of this is if you ask them, how did that go? What would you do differently next time? You very rarely need to say anything because they'll do it all for you. And it's so much easier that way. So feed forward is very key. And then make a plan for improvement and then do new goal setting. And you can just do this on an informal basis with all your trainees. And I'd also encourage them, just like Rima was saying at the beginning about watching their own performance. Athletes are doing this, musicians are doing this, surgeons should be doing this. Um, and that ability to self-reflect, it's painful to watch yourself operate. Like, it's like, why am I doing that over and over and over again? It doesn't matter how good you are, you realize you could be more efficient. And then the other thing you can do is watch videos asynchronously. So you take the resident, the trainee out of that pressure situation, you put them in this calm, quiet environment where there's no pressures. You can actually teach, or you can be more of a coach-like teacher or coach-like mentor to try and help them improve their performance. I think that's very powerful for learning. And I'm just going to end here because we want 10 minutes for questions. If you're interested to learn more, here's a link. You can we'll also put a document, I think a PDF in the chat as well. The Academy for Surgical Coaching offers, if you're interested in becoming a coach, they do coach training. And then they have all these other 5 different offerings, executive coaching for leadership. They do specific surgical coaching. They do this focused professional growth coaching, but that's mainly for people who are struggling and need remediation, and they're kind of brought to the program by an external source. And then coaching for fellows is new. And then they have this amazing institutional surgical coaching program where they'll set everything up for you. So they train the coaches, they create everything that you need, and then you can just take it to your hospital. Obviously, it costs money. I don't get any of it, so there's the non-bias. There is another US organization called Surgeon Masters. Feel free to look it up. I'm just not affiliated, but I've heard good things. So feel free to explore. And I'm going to stop there. So thank you. Happy to take questions or send it back to Cynthia.
I just wanted to clarify, there actually is not a way to send out that information about the coaching program. You're on mute. So if we can't figure out how to send it out during this webinar, we will send it out with the recording.
Are the questions visible to everyone? So if you put it in the question location.
There's no way for us to ask questions because we're the panelists.
Oh. We can see the questions, we just can't add them.
That's okay. We'll go ahead and send it out with the webinar recording so everyone has access to that.
I'm not sure if there are any questions yet on the chat, but I had one for Jane. Is that okay?
Yes, for sure.
Okay. How do you navigate like patient privacy and all of that with, video recordings? Do you have to get special permission from the hospital to be able to have been able to initiate a program like this? Yeah.
Yeah, so it's very different north of the border. So this is deemed like quality improvement work. And so it's anything that is improving quality, people just will let you do. So we didn't really have to get approval. They just needed to know that we were doing this program. We have a coaching and mentoring program embedded within the university that is involved with surgeons as well. So it's not new in a lot of ways, so people are familiar with it. What we did have to do is get the nurses on board because they were wondering why someone was sitting in the OR. Because we did a lot of live coaching where you'd sit in someone's operating room, which was really, an ideal world, but that's very time intensive. But you get to see the technical, the non-technical, all of those things. So yeah, it's very different in video review as long as there's no identifiers like we did today. There's no demographics, no identifiers, especially with our field. Usually there is not, but sometimes there is. Depends what, facial plastics and different things you may be able to identify. So for us, it's fine, and everything's kind of HIPAA compliant in terms of sharing through different platforms.
So there was a question that asked about how do you put a GoPro on in terms of sterility. So the clear camera drapes are what can be put over the actual GoPro, but because it was chest mounted, I had I had an additional scrub tech have sterile gloves on to cut a hole. So I mounted it first and then gowned, and then they cut a little hole for the GoPro to stick through, and then we just put a little sterile like yeah, like a not an opsite, but they have camera drapes, but they're kind of expensive. So we use something that's kind of more like a 1010 or something that was clear. And there was an actual hole that was not that was left open, so the camera portion of it would not have to go through that. But it was very simple. It was literally like snip, push the camera through, and then put this little covering on top so that I could actually move it if I needed to. But I found that once I put it on and I oriented it, I could actually tilt my head down, look through the bottom of my loops, and see what was being recorded. So it was pretty easy.
And Lakeisha, I think you put a question for me in the chat. Do you want me to address that to the group?
Sure. I mean, just, you said there were a lot of different directions, so I think it would be helpful.
Yeah.
Just
so
curious.
Coaching, the sessions are usually an hour, 45 minutes to an hour. So there would be so many different avenues. So, the cognitive skills in terms of decision making of when do I stop trying to fix it and when do I just need to either abort or continue without a piece of equipment. So those are the things, but that would take so long to unpack. That's why I didn't go there. That would be something that would be very valuable in terms of efficiency. So, maybe I don't know what time frame that started. Maybe it was 35 minutes that you were like, I'm just going to do this thyroid because I didn't see the whole thing. Those would be something I'd go through. And then, talking to you a little bit about managing cognitive load, because when I watch the video, you turn the music off quite early. So you've already taken steps, but a lot of things are happening. Other things that we could talk about is maybe communication. Your calmness really comes through. The thing I never heard a name throughout the entire recording. I never heard anyone say like Lakeisha, Jane, Tom, Bill, Sarah. I never heard a first name, which is a bit unusual when I listen to it. Those would be things that I'd probably kind of go through. And then really what I'd be trying to figure out is how do you have such good stress and coping mechanisms? Because then I'd be like, I want to switch and I want to be a coachee because I want to learn from you on how you are this duck, where nothing seems to ruffle your feathers. So the strategies of how you learn that so you can teach others, but also so that others can learn from you, because answers come from anywhere in the room, as you say. So I would love to learn that. That's sort of where I would love to go if we had more time.
Absolutely. Generally, we use names. I didn't because we were recording.
Oh, that makes sense.
And so
Oh,
I didn't want to
okay.
reveal anyone's name. And so it just made it easier. I said early on, there's the audio is recorded. So I'm not going to use names. But
Right.
and so everyone just basically kind of went from there. You might have heard well, in other parts of the video, you'd hear someone, say my name or something like that. But for the most part, I didn't. I just looked directly at people. Or because we were so close, I could actually touch someone's hand.
Yeah,
To,
and
you
you
know,
can't see that all the time. I
yeah,
saw a lot of the floor or
yeah.
different parts of the drapes.
Yeah. Well, that's when I stepped back for that part of the video or that section. There was a lot of me standing back to
Yeah,
get, we were changing things, changing chords, unplugging stuff, and I didn't want to be trapped in anything. So I stepped back for some of that.
excellent. And I'm just cognizant, is there any questions from the participant, like anyone online that wants to ask more questions or, oh, there's one.
Yes, we have one basically asking, when a surgeon comes to you with a specific aspect of their surgery, cognition, technique, or collaboration, etc., what materials do you ask for them to provide you in order to better coach them, unless you have the opportunity to sit in person or on a surgery?
So I think this is a personal decision based on what the coachee is comfortable with. Most people don't need to bring anything external. They have very good insight and they can describe what's going on and what they were struggling with, unless it's a very specific technical thing. More often than not, you can move forward as long as you have permission to challenge them and challenge their own story and their perspectives, which is part of that co-creating the agreement. Usually you can really get anywhere and uncover things that are kind of hidden underneath that iceberg that the person's not aware of. So I don't think you actually need anything. Most of the time I'm doing coaching, except with some new to practice people. It's often not technical.
And it looks like we have a comment that says, ready to adopt at our residency, start the improvement early, last for a cares? I'm not sure if that was a typo, but yes, that's great. We should definitely start it early and normalize it. Okay, great. I think we're going to go ahead and wrap things up. We are over time just by a minute. Just wanted to say thank you to Dr. Padilla, Dr. Lee, and Dr. Henry for attending and sharing your expertise, and Dr. Henry for showing such a vulnerable part of your day-to-day surgery. So thank you, and I hope that this was really helpful for everyone. Be on the lookout for a recording that'll be sent out, and be sure to share it with your colleagues. All right.
It's definitely not my norm. But it made for a very good video for this. So
Absolutely. Thank you so much, everyone.